Hello, everyone. I'm Dr. Ojile from Nigeria, and I'll be your host for today's GLODEM webinar series for the month of December. And we'll wait a little for more participants to come in, and then we'll start. Welcome, everybody, once again to the GLODEM webinar series for the month of December. Today, we have the honor of Professor Saunte, who will be talking to us on dermatophyte resistance. Also with me are meeting hosts, Dr. Mulanga from South Africa, Dr. Karen from Kenya, and Dr. Memory from Tanzania. Our meeting etiquettes is as follows. Your audio will be muted and your camera will be turned off for the duration of this webinar. If you have any questions or comments, please submit using the chat function or the Q&A button. Our meeting host will share this with the speakers to answer at the end of the webinar. We'll also be sharing further information about the GLODEM training committee in the chat function. So the GLODEM training committee is the International Alliance for Global Health Dermatology, and our vision is to promote knowledge equity by improving access to education for dermatology trainees across the world. We aim to provide free educational events and opportunities to build networks and collaborate. Our talk today will be presented by Dr. Ditte Marie Saunte, and she'll be talking to us about dermatophyte resistance.
Thank you very much for the kind invitation to give this talk about dermatophyte resistance. These are my disclosure, and I just want to warn you about there's going to be some off-label use of pharmaceuticals in this presentation, and also you may be aware that the guidelines change over time. So if you look at this recorded video, then the things that I'm saying here might be outdated, so you have to look into the latest guidelines for updates. This is the agenda of today. I'm going to give you a short introduction and something about diagnostic, antifungal resistance overall, and then more details about antifungal susceptibility testing, treatment, prevention, and then some take-home messages, and then we'll end up asking you some multiple choice questions. But first, we'll start with the introduction, and I would like to share with you one of my patients first, a case of a 40-year-old woman. She's been visiting India and she returned to Denmark with this initial small scaling ailment on her leg. And it was regarded as eczema here in Denmark and was treated with topical steroid. And there was also taken a biopsy which showed fungal hyphae located in the keratin layer. During steroid treatment, the disease progressed as shown here on the right. It progressed from the legs to covering most of the body, including the face and arms and truncus. And the mycological diagnosis was made, and it said that the patient had a trichophyton mentagrophytis / interdigitalis complex infection, and initial treatment was terbinafine. But even though she was treated with adequate dose, 250 milligrams a day, the treatment progressed during the treatment. So we performed our antifungal susceptibility testing, and it turned out that it was terbinafine resistant and itraconazole sensitive, and therefore her treatment was changed to itraconazole. And it's a bit difficult to see, but if you look more in detail, you see there's some skin scales here in the initiation of the itraconazole treatment, and then all the scales has disappeared 6 weeks after the treatment, but the patients still have hyperpigmentations in the area of infection. So this is the overview of the fungal infections of the skin. And just to show you that dermatomycosis, I find it very convenient to divide it into yeast, which are a part of the normal flora, like Candida on the mucosa, Malassezia on the seborrheic areas of the skin, and then we have the molds, where we have the non-dermatophyte molds like Aspergillus, and we have dermatophytes. And the dermatophytes are the theme of this day. And when we look into dermatophyte, they are keratinophilic fungi. They can infect both the skin, hair, and nails, and they're regarded as primary pathogens as opposed to the Candida, which is a part of the normal skin flora, the mucosa flora. And then the infection with these dermatophytes are called dermatophytosis in Greek, tinea in Latin, and ringworm in English. And they got that name because they start initially in the center, and then they grow markedly um, centrally out, and they make this ring appearance on the skin with an elevated border, which is with skin scales. So then we're going to talk a bit about the diagnostic methods, and it is about taking the right sample, and normally it's taken from the edge of the raised border, and then we perform it by taking it to the laboratory, where we take the skin scales or the nail or the hair, whatever the sample is, and it is we perform a microscopy and culture. By doing microscopy, we take the tissue and prepare it by dissolving the keratin, and for that 10 to 20% potassium hydroxide solution or sodium hydroxide, something very basic, um, can be placed on the specimen to dissolve the keratin, and then it should be dyed with something like lactophenol, cotton blue, or something that makes it fluorescent under a microscope. And the next slide here, we have a fluorescent microscope where the dye binds to the fungal cell wall, and you will see here that it enlightened in our microscope, and you see here very nice septate hyphae in this hyphae of a dermatophyte. So by direct microscopy, one are able to see is the fungus present or not, is it there or not. We're not able to see what kind of species is it, or we're not able to see if it's alive. Then we have the culturing, where we place the specimen on a culture plate, here a separate agar plate. And when we look for dermatophyte, we add chloramphenicol in order to reduce secondary contamination with bacteria, and cyclohexamide, which reduce the growth of non-dermatophyte molds. They grow quite fast compared with dermatophyte. So on this agar plate, the dermatophyte and Candida albicans can grow. And this is how a culture might look like. To the left, Trichophytes and Mentacrophytes, which is a bit powdery, and to the right, a Trichophyton rubrum, which is more feathery when we look at them. We cannot see, just looking at the culture plate, what is the specimen or the genus of this fungi. So we take a sampling from the culture, add it on a slide, and then we perform we do microscopy of the culture. And by that, we'll look into the culture, the hyphae of the culture, and look into the microscope, and we'll see more in details here. We have the hyphae, and we have some microconidia, and sometimes also macroconidia. And in this case, it was an example of Trichophyton interdigitale. But how do we know that? We look into the details, and then often we compare with a lot of fungal atlases, where there is examples of other um, of other direct microscopy, and we can compare in order to make the diagnose. Another methods of making the diagnose is to perform direct microscopy. Molecular biology. And in some countries, it is a routine way of making the diagnostic. We do that here in Denmark. It is quite fast. Within a few hours, we are or days we're able to give the diagnose, and this is fast compared with the culturing, which can take up to 4 weeks before we have the diagnose by culturing. So it is a fast way of doing diagnostic, but it's not available all over the world. So by using the molecular diagnostic and do sequencing, there is now identified new genera compared with before. So the dermatophyte has now got a new taxonomy. And here you see the names of the 9 genera, where the more highlighted one, Microsporum, Epidermophyton, Trichophyton, and Natroderma, are the most common, which are isolated in human and animals. So they are still the most common one, but you should just be aware that there is other genera. Then why is it important to perform diagnostic? It is important because often when we do treatment, it is a genus and species direct treatment. Um, so we choose the treatment according to which dermatophyte which is isolated, and then we also use the information to see if the dermatophyte is anthropophilic. That means that if it is transferred between humans, or if it's zoophilic, where it's transferred from an animal, it has an animal host, like for instance a cat. It's often a host of Microsporum canis, and from there it can be transferred to a person. So if you have a person with Microsporum canis infection, then you should look for the cat for the source of infection. And then we have the geophilic dermatophytes, which are sometimes transferred from the soil to a human. For instance, Nanesia egyptium is a dermatophyte which is living on keratin material in the soil and can be transferred often to people working with their hands in the soil, and it can cause, for instance, tinea manum, an infection of the hand. Okay, what is antifungal resistance? This is a very simple drawing of fungi. Fungi are eukaryote. They have a nucleus where they have chromosomes in. They have a cell membrane, which is consists in fungi of ergosterol, where it in human consists of cholesterol. So there's a difference there between the fungal cell and the human cell. And then it has also a fungal cell wall, like plants have a cell wall, and this cell wall is made of a manoprotein, chitin, and beta glycan, and these differences are often the place where the antifungal therapy are targeted. And the next slide is quite busy. This is where systemic antifungal works. And when it comes to dermatophytosis, I'll just show you here. We have the alalamine like terbinafine. It inhibits the production of ergosterol by inhibiting the conversion of squalene to lanosterol by squalene epoxidase. So when we sometimes have patients here resistance to terbinafine, it has a mutation in squalene epoxidase. Then we have the azoles. They block the conversion of squalene to ergosterol on a later step um, in this area here. So there are 2 different antifungal classes. So if one of them don't work, then often we change to another drug class. So these are the most important here for dermatophyte, and also cresifulvin is often used for dermatophytosis, and it inhibits the mitosis in the nucleus of the for the chromosomes. If we look here, still a very simple fungal cell, we have different way that antifungal resistance can occur. We have the antifungal drug, we have the efflux pump here, we have a drug target and a mutated target. And often we have an upregulation of the efflux pumps, so that the drug which is inside the fungal cell will be pumped out of the cell very fast, and that have been seen in azole, in cases with resistant to azole, alalamine like terbinafine and cresifulvin. Then we have an overexpression of the target drug, where we have here the drug target right here, And if there's a lot of them and this is the drug, then there is a less efficiency of the drug. Then we have a mutation in the drug target, so that the antifungal does not really fit, and that is what is seen in the squalene epoxidase gene mutations. And then finally, the fungus can change so that the drug is not um, able to penetrate the cell and be into the fungal cell. So it is rejected at the surface of the cell. So, is antifungal resistance very rare? Well, it had been noticed for many years. The first reported was for glycifulvin resistant in the 60s. Azole resistance had been reported in dermatophytosis in up to nearly 1 out of 5 patients in different certain regions of the world. And then we have the terbinafine resistance, which has been um, increasingly seen since 2017, and mainly in Asia and mainly in India. And you see that also if we look into the PubMed searches, that we have an increasing number of publication on this subject too, indicating that something is happening here since 2017. So I just want to introduce to you a multi-center study from India, which was published in 2022, where they have been um, screening nearly 40,000, more than 40,000 patients, and they found that 17% of those had a dermatophytosis, and of those again, nearly 5 of them had a chronic and recurrent dermatophytosis, and also relapsing was very high, and this was found from 19 centers in India. Another Indian study here, it's a review made of Shyam Verma, a very dear colleague from India. He reviewed some publications from India, and these are patients that had a superficial dermatophytosis. So they were diagnosed with tinea corporis, and among those patients, overall, nearly 60% of those had a chronic infection, 40% a recalcitrant infection, and up to 60% had a relapse after they were treated. So it's a quite high number of relapse or chronicity among these patients in India. So this is just how it looked in the publications by Shyam Verma. And just to show you here, it's very, very widespread infections which are covering the patients, very severe, much more severe than we are used to see. So, is it common in other countries? We did this survey among dermatologists in Europe, where we asked them that they have seen dermatophyte antifungal resistance. And these are the answers that we got, that those in orange, they are countries where it had been reported. Those in the blue are those who had been published from their countries before they had antifungal resistance. Those in gray were not included, and there was only one country reporting that they have never registered antifungal resistance there, and probably because they did not really look for it yet. So, but also we have to be aware that antifungal susceptibility testing was only available on request in 55% of the countries. So we have a problem to confirm that there is antifungal resistance in most countries, I think worldwide, as a routine diagnostic. Just to show you here some headlines from publications, publications where antifungal resistance among dermatophytes are quite widespread, and also now not only in India with but also in patients with tinea capitis. So we have to be aware that antifungal resistance exists among patients with different kind of dermatophytosis. So, what is antifungal resistance? Well, we have the clinical antifungal resistance, where there is no response even though the dose are correct. And then we have mycological resistance where there might be a primary resistance. For instance, what we see in Candida glabrata, which is not sensitive, susceptible for fluconazole. And then we have a secondary acquired resistance in patients who have been challenged with antifungals before. So I'd like to introduce to you another of my cases. This is a 72-year-old man with trichophyton rubrum infection. He had had this relapsing fungal infection since he was young, and he had been treated before with oral itraconazole, oral and topical terbinafine, and a lot of over-the-counter antifungals, and he didn't remember the names. And it's very, very usual that the patient also borrow antifungal from their neighbor or family members because they are very widespread to use and very easily to get. Okay, when we look at this patient here, what might be the reason for the chronic infection? Well, it might be because when he got his itraconazole, the antifungal was not being absorbed properly from the stomach. And you have to be aware that the itraconazole is best observed in an acid environment, like in grape juice or after a meal or with Coca-Cola. Um, so sometimes it's not absorbed from the stomach properly, and in some countries one will be able to determine, measure the concentration of itraconazole in the serum. Sometimes it's because that the antifungal treatment is not able to penetrate the area of infection. For instance, if you look here at the nail, you will see there's a whitish area with a dense clump of hyphae. It's a dermatophytoma, and it's very difficult for the antifungal treatment to penetrate this dense fungal material. So, and then one should always ask oneself, is the patient compliant? Does the patient eat the treatment as prescribed? Just to show you here that the level of itraconazole is important. This is a study from India where they had 40 patients which were itraconazole naive, had never been challenged with itraconazole before, and they had a tinea corporis or cruris, and they were all randomized to having itraconazole 100 milligram, 200 or 400 milligram a day. They all had a trichophyton induthenia infections, which were sensitive to itraconazole, so it should work, and then they were resistant to terbinafine. So in these cases, they found out that the serum levels achieved with 400 milligram itraconazole per day was significantly higher than the lower doses. That's quite obvious, but also that there was a treatment failure if itraconazole serum level was under 0.2 microgram per milliliter. So it is possible to measure if the level of itraconazole is high enough to help these patients to cure. So, okay, if it's difficult to observe from the stomach, would it then be easier to observe using this super bioavailable itraconazole? And that was investigated by these authors here, Chinoy from India, and published this year. And they divided patients, 260 patients, into three groups. One group receiving super bioavailable itraconazole, 130 milligrams once daily. Another group receiving conventional itraconazole, 200 milligrams daily, and one group receiving itraconazole 100 milligrams twice daily. I would say the same dose of conventional itraconazole, but given in two different ways. And when we look into their results, there was a complete cure rate of the super bioavailable itraconazole of 70% in the patients, in the 200 milligram once daily, 60% of the patients, and the 100 milligram twice daily for 46 percent of the patient was completely cured. But there was no statistical difference between the morphological cure rate, and then there was a statistical significance noticed in once a day dosing over twice a day dosing. So maybe the patients do not adhere properly to twice a day. That's difficult for me to say, but nevertheless, there is not really in this study a difference between the super bioavailable itraconazole compared with conventional itraconazole. So, but there's other studies than this. Okay. So we have here a patient where we have a clinical non-respondence, and when we have to make the definitions, we have the recalcitrance where there is no response to standard first-line antifungal therapies, even though the dose and duration are correct. And then we have the recurrent patients where we have a relapse within 4 weeks after completing a standard first-line oral antifungal therapy. So both of them should make a suspicion of dermatophyte antifungal resistance. Okay, then we have the mycological resistance too. And if we look into our first case, our first patient, she had a trichophyton interdigitalis integraphyte complex infection. She had a very widespread infections, and after sequencing that isolate, it turned out that it was trichophyton indutinae. And I just want you to be aware that there has been a lot of confusion about this species. It had been formerly called Trichophyton type 8 and interdigitalis, and also interdigitalis / Integraphytes complex. And I just want to show you a very busy figure from a publication by the German group with Silke Urlas as the first author, just to show you here that in 2020, 2007, there was a lot of different names of the Integraphytes, Integraphytes complex. They had different subspecies. Then in 8, it changed into zoophilic species. And then again, it's changed its name again. And now it has been divided into a lot of trichophytes and integraphytes, ITS genotypes. One which is now called Trichophyton indutinae, and another one which is Trichophyton interdigitalis, which is mostly anthropophilic. And these are, it's only possible to differentiate between these by using sequencing. So it's not for everybody to do, but just as you're aware when you read in the literature that they might have different names. Also, why do we think that it has changed? Well, this new Trichophyton indutinae is more contagious than others, and it has there is some hypothesis that has been proposed that this used to be a species that was residing on a wild animal, borrowing a wild animal like a rabbit, and it was transferred from this animal to a domestic animal like a cat, and from the cat to the humans, and the human, it was divided into some clones, where one of them are now Trichophyton indutinae, which is very contagious. Another one is Trichophyton interdigitalis, turned out now to be anthropophilic and able to be transmitted between humans and cause epidemics. So this new Trichophyton indutinae species has caused a big epidemic, especially and initially from India, but it's also been noticed in other places in the world. And it is supposed to be responsible for these chronic and very recurrent widespread superficial infections. Also, they are known to be terbinafine resistant. Up to 3 out of 4 of the patients, the isolates are terbinafine resistant, and therefore the first drug choice is itraconazole. And you have to be aware some of them are also azole resistant. So they might be considered primary resistant. We don't know that yet. Well, another theory is that it has been developing this antifungal resistance due to improper use of antifungals. This is from Professor Shyam Verma from India, who's published this about over-the-counter medication in India and the very widespread use of a combination of antifungal with topical steroid and also antibiotic in one cream, and that this about having a steroid combined with antifungal a kind of lower the immune response, and also maybe the level of antifungal concentration is low, so that will do a selection so that only so there will be a good environment for developing antifungal resistance. Also in these patients, you notice that some of them have these concentric rings of infection, and this is called tinea pseudoimbricata. Pseudoimbricata is a special form of tinea incognita, and incognita is when you use a steroid on a fungal infection, you will have this a bit different clinical sign, and it is the theory is that it is the add on and off of the immune system that make these rings on the skin. So sometimes the antifungal works, sometimes the immune system is lowered by the steroid, and that will create these rings. So if you see this ring, be especially suspicious for antifungal resistance too. So what about this antifungal resistance? We have here the patients from before, the old man, which had been challenged with a lot of different antifungal therapy. And as I told you, it is very easy to get antifungals as over-the-counter medication. This is a picture I took once in US, and you'll see here the shelf are full of antifungals that you can buy without a doctor prescription. You can keep it at your home for years and use it, and then it's working less efficient, and there's a risk of that you, if you use it improperly, that you can um, develop antifungal resistance. So if we look at our case here, he might have a secondary acquired antifungal resistance by using antifungal therapy on and off over years, and then a selection will occur or a mutation will occur in the fungus, giving this antifungal resistance. Other explanation might be that the patient is reinfected. For instance, he's using his socks, not cleaning them properly, so he might reinfect himself. Another thing is that he might also have a dermatophytoma in his nail. There is a source of reinfection, or that he had been traveling to endemic countries, or that he is using public bath facilities, so that he's reinfected a lot of time. There's a lot of explanation why a person might having a reinfection or having a chronic infection. So, but in my case here, in this patient case, the patient, the isolate that he got, his trichophyton rubon, was azole resistant, probably developed over time as a secondary acquired resistant. Okay, now we're going to talk about these secondary acquired resistance and how do we make that diagnose, and that could be done by performing antifungal susceptibility testing. And I'm just going to show you a variety of antifungal susceptibility testing, as it is a big mess, a big football of different methods that have been published over time. So, but the most important thing that you should remember from this is when you perform antifungal susceptibility testing on a culture, then you provide information of the specific isolate for that specific patient, and that is very important for that specific patient to know the exact MICs of his or her isolate. So it's specific for the dermatophyte that is isolated, but you also have to be aware that the dermatophytes are very slow growing. As I told you before, sometimes it takes up to 4 weeks for a dermatophyte to grow in a culture. Sometimes they have a very poor sporulation and use the spores often to inoculate the agar plates. And just an example here to the right are the microscopy of Trichophyton rubrum. Very, very few fungal spores. And often also there is a contamination of other fungi, even though you um, harvest the cultures from something you think is a pure culture. So how do you perform that? I'll start to introduce to the disc diffusion method. For this testing, you have your nucleum with the fungal spores, and then you add it on an agar plate. And on the top of that inoculation, you add some disc with different kind of antifungals, F for fluconazole, G for grisifulvin, I for itoconazole, and T for terbinafine. And after time, the fungal will grow, and you'll see that these different discs with antifungals on will inhibit the growth of the fungi in a zone around them. And in this specific case, there is no inhibition around the terbinafine disc, so this is a terbinafine resistant isolate. Another method is the E-strip. You have here a strip with antifungals on, a high concentration here on the top with 32 and lowering down the strip. And then you have an inoculation with on the agar plate, and again you will look for where is the lowest concentration that inhibits the growth of the dermatophyte. That is the MIC, the minimum inhibitory concentration, and that is the the number that you should record. So another test is agar dilution method, where you have a pathogen to be tested is inoculated on each plate, and you have different concentration of antifungals in each plate here, highest to lowest, and then you incubate your um, your agar plates in a specific temperature of 25 degrees and incubate them at a specific time. And again, here we have the MIC as the lowest concentration, which inhibit the growth of the dermatophyte. Another test, the macrobroth antifungal susceptibility testing. Again, we have the pathogen to be tested to be inoculated on each tube, and we have different concentrations of antifungals in the tubes with a high concentration to the left, lower to the right. And then we have the growth of the fungi is here on the top of the lowest one. And then the MIC is the lowest concentration that inhibits the growth of the dermatophytes here. Then we have the microbroth antifungal susceptibility testing. These plastic wheels can you can have a lot of isolates on the same plate. We have a higher concentration to the left, lower to the right. We have a negative wheel here and a positive control here. And then we have the growth of the dermatophyte. Sometimes there is a color that indicate when there is a growth, and when uh, uh, this is where the growth is the pink, and where there's no growth, it is the right. So there is an indicator in when there is a growth and when there is no growth on the agar plate. There's a lot of different screening methods too. Some of them are mentioned here to screen for terbinafine resistance. The thing is that there is only two standardized susceptibility testing method. One of them published by UCAST, the European Committee on Antimicrobial Susceptibility Testing, and one from this is a European one. Then we have one located in US, Clinical Laboratory Standard Institute. These are the only standardized methods. And the UCAST has a special one for dermatophyte, where they have added cyclohexamide and chloramphenicol in order to reduce the contamination of the plates while performing the susceptibility testing. And from UCAS, they also have no really breakpoints, but they have what's called the epidemiological cutoff values, and that is a value some differentiate between the so-called wild type of the isolates and those which are non-wild type. They might have a higher MIC, which might be um, mutated. And if you look into those tentative cutoff, we have here for terbinafine, we have the trichophyton indutenia and a cutoff value for terbinafine 0.125, and it's a bit lower for trichophyton rubrum. So, and this may indicate that trichophyton indutenia have an inborn um, uh, lower susceptibility to terbinafine than, for instance, trichophyton rubrum. It is also possible to detect antifungal resistance, to detect if there is mutation in the target genes, for instance, of squalene epoxidase, and that can be done by sequencing. There is also a commercial available kit for this, which has been shown here on this slide. So there is different ways of detecting antifungal resistance. So this is also widely used, and these are the published squalene epoxidase mutations from worldwide. So just so that you're aware that it is possible to perform that as well. Mostly it has been, it is not a routine test, but it may be in some laboratories. So now we have detected the dermatophyte resistance. Now we're going to treat the patients. So if we have a patient where we are suspecting antifungal resistance, then we can change the drug, antifungal drug class, for instance, for terbinafine to an azole treatment. We can also combine the therapy with topical and systemical therapy. We can also combine antifungals with other medical therapies, and we can also use two different antifungal classes as one, giving a higher dose and maybe also other things. And I'll just go back to my first case that I presented for you, which were terbinafine resistant, but was itraconazole sensitive. We changed her to itraconazole and she responded very well. This is in line with the Indian consensus guidelines from 2020, where they suggest that chronic recalcitrant or steroid modified tinea should be treated with itraconazole. As first line therapy together with terbinafine, and it's a higher dose than normally suggested for terbinafine, twice daily, or crisaformin and fluconazole. Just to show you here that they often suggest a combination of systemic and topical antifungal therapy. Also, topical antifungal should be continued longer than the clinical resolution, at least 2 weeks more. And it suggests that the first line therapy should be itraconazole or terbinafine for the patients, and that crisaformin and fluconazole is only used as alternative medications. And they suggest that terbinafine should be used in terbinafine naive patients as first line therapy. Also here, they suggest that a longer duration of treatment for patients with chronic or recurrent steroid-modified dermatophytosis is suggested. Okay, then we often have these special patient group, women being pregnant or lactating, and they suggest that it's only topical antifungal that should be used for that, and they suggest that we try to avoid using systemic antifungals, even though terbinafine is categorized as number B in drug safety, but the human data are very scarce. So they suggest that if possible, don't use systemic antifungal for pregnant or lactating women. Children under 2 years, if it's a limited infection, use topical therapy. or use fluconazole in these patients, which is considered safe for smaller children. In elderly, be aware of that they often get other medications, so be aware of drug-drug interaction, and also be aware that if they have a liver or kidney disease, try to avoid drugs that is or reduce the dose of the drugs for these patients. This is a very interesting study which has been published of Katab and colleagues in 2022. They did a study where they divided the patients into one group receiving itraconazole monotherapy, 200 milligrams a day, one receiving itraconazole combined with isotretinoin. And isotretinoin, because it is keratinolytic and had immunomodular effect. And then voriconazole, which is third generation triazole antifungal. So if we look into these three groups, and after 6 weeks of treatment, you'll see here that those patients receiving itraconazole as monotherapy had a response, logical response cure rate of 56, and those with combination of itraconazole with isotretinoin was 83%, and those with mycological those receiving voriconazole had a mycological cure rate of 87%. And also, when we looked into the recurrence rate, that is a big difference. So 1 out of 3 had a recurrent infection in the itraconazole alone group. 1 out of 3 in the itraconazole combined with isotretinoin group had a recurrent infection, and those with voriconazole was only 8%. And why don't we only use voriconazole alone? Because it is expensive, and there is also some side effect there. But nevertheless, it's an option, and that option has been looked into. These authors also from India, Kandraskar and colleagues, and they used voriconazole 800 milligram once daily, followed by 200 milligrams twice daily for 14 days, and they observed a complete clearance of 90% of these patients. And at week 6, it was a complete clearance of. It has lowered a bit to 75%, and 20% but partial improved, and the current rate was 50%. Sorry, the week 6 was the follow-up after these 13 days of treatment. So it was quite a good response rate. And you have here A is before the treatment initiation, and B is at week 6 in these patients. So, but we have to be aware that some of these patients are also resistant for azoles. So what could we do to treat those patients? Well, this is a study where they combine oral terbinafine with oral itraconazole in these patients. They have 3 groups, and there is 20 patients in each group. Terbinafine once daily, a cure rate after 3 weeks of 35%. In group 2, itraconazole once daily, a cure rate of 50%, and the combination of these two, a cure rate of 90%. What I would be a bit worried about is adverse events, the side effects of these patients, and this is what they have recorded. They have here in group 1, which was terbinafine. Once again, terbinafine alone, that was a headache, the main one. We have the group 2, which was the itraconazole, and group 3, which was the combination. But there's not really a big difference between these groups. And I just want to warn you about this, is that there's no really big, large scale trials on this, which report on the safety and efficacy of these combinations, but it looks a bit like the side effects of this combination is nearly the same as what you get from the individual antifungals. Then there has been some vitro experiments using combination of different antifungal combinations, and it seems like, at least in vitro, that there is both additive and synergistic effect of combining all these different kind of antifungals. Then we have in the horizon new antifungals coming, and maybe some of them will be advantages for using in these patients with terbinafine and itraconazole resistance. Time will show us that. Before ending my talk, I'd like to talk a bit about prevention, because I think it's very important. We have here very good opportunities for our patients to get reinfected. So by doing sports, by just living with other people. So when you have a bare feet, please use socks, or you can use flip-floppers in order to protect yourself of getting reinfected. And then we did a study here in Denmark, because we have always been telling our patients to wash their socks with 60 degrees, which is working. But what can you do if you have a clothes that's not able to be washed more than 60 degrees? We wanted to check out if we could freeze the dermatophytes. So we inoculated both terbinafine susceptible and resistant dermatophytes on socks, and we freeze them for half an hour, 12 hours, and 24 hours. We washed them at 40 degrees, and we did steam washing, and there was really no or very little effect. Then we soaked them into this quaternary ammonium detergent, which is thing that's at least in Denmark a part of sports washing, which is commercial, which is available in normal shops for sports washing. And we soaked it for half an hour, 2 hours, and 24 hours, and there was 100% clearance rate after 24 hours soaking in this. Also for the terbinafine resistant dermatophyte, so we can suggest that as an alternative to washing for more than 60 degrees. So, but we know there's a difference between our opportunities. This is a picture I took when I was in India. This family has very little chance of getting rid of an infection if they get it, because how could they wash their clothes with more than 60 degrees and clean all their surroundings here? So with that, I will end my talk. And the take-home messages of this talk is that antifungal resistant dermatophytosis is increasing worldwide. Treatment should ideally be prescribed according to the dermatophyte species involved, the antifungal susceptibility testing results, and the knowledge of earlier treatment. Also, patients need a longer duration of treatment. It's recommended, and chronic and recurrent and steroid modified dermatophytosis need a longer treatment. And then finally, the patient should be followed up clinically and mycologically in order to assess the treatment response. And with this, I'd like to thank, and also, of course, we should prevent it if possible. And with this, I'd like to thank you for your attention. I'd like to thank you, Glodem, for the invitation to give this talk. Thank you.
Thank you, Dr. Ditte, for your presentation. Now we go over to the polls, which will be headed by Dr. Karen.
Hello, everyone. Thank you for attending the talk. So I'll just go on and launch the poll. So I hope you can see the poll and that you can vote. Okay, I'm seeing some responses coming in. Keep them coming in. Thank you. Okay, half of us have answered. Maybe the rest of us can go to the poll section and answer. The question asks, when should you suspect antifungal resistance? So yeah, those are the choices. Go to the poll section, please. Okay, so I think I'll stop sharing. That's a good response. So the choices were chronic infection, recurrent infections in elderly patients, when steroid and antifungals have been used in combination, and all the above are correct. And yeah, so I'll stop sharing and I'll share the results. Hope you're able to see the results. Okay, so we can go on to
Yeah.
the second question.
Do you want me to comment on the answer?
Oh, yeah.
I just want
Yes, please. Yes, please.
the elderly patients, that depends, of course, of if they have been treated before. Just because you are elderly, you don't need to have a resistant infections, but the risk of that they have been treated before is of course higher. So I think all of you got it right.
Okay. So we'll go to the second question. I've launched it. You can go to the poll section and vote. The question is culture-based methods, antifungal susceptibility testing, and then there are two choices. So kindly go and put in your answer. Thank you. Keep putting in your answers. I'm seeing a good response. Okay, so that's almost half of us who voted. Okay, so maybe Prof can comment.
The culture-based methods tells you about the specific isolate from the specific patients, where the squalene epoxidase is a mutation that you detect, and it doesn't tell you about the MIC values of the patients, just tell you is there a mutation, yes or no. So you're right, most of you.
Okay, and the final question for the day. Okay. Okay. So the question asks, how long do you continue antifungal treatment? Okay, so maybe Prof, you can comment again.
Yes, it's a bit tricky question, because ideal, I would until complete cure and mycological, clinical and mycological. But very often, if you remember the pictures of the patients, you will see a hyperpigmentation after the fungus has been eradicated, after the mycological cure. So I think in patients, I continue until mycological cure, and then I hope for that the patient, over time, the hyperpigmentation or the hypopigmentation would disappear. So I think that the main thing is to continue until mycological cure, which may only be a direct microscopy. But of course, ideal is also to have the patient clinical cure.
Okay, thank you. I think I'll hand over back to Ujile.
All right, thank you, Dr. Karen, for the poll. I want to say thank you to Professor Saunte for an interesting talk on dermatophyte resistance. It was a very enlightening talk. I also want to thank our meeting hosts and co-hosts for today. We also thank participants from around the world who joined this webinar. We hope that you found it interesting. You can rewatch this webinar on YouTube, as well as follow up on our past webinars. Be sure to follow our social media channels for webinars, for the webinar for the month of January and other events on GLODEM. Thank you very much. Thank you, everyone.
Yeah. Right. There were two questions that were posted here. I'm not sure if Dr. Saunte is still available.
Yes, I'm here.
Yes, no, thank you so much. So there was the first question from Anonymous that said that thank you for the presentation. Apart from the antifungal medication and ensuring correct dosing, are there other options of treatment for resistant dermatophytosis?
Well, there is some publication on PDT treatment. There will be disinfection, but I'm not sure that that works. But PDT treatment has been published for different kind, and we did a study, but it's only a laboratory study on this. I can't remember anything else, but there probably will be other more mechanical way of treating patients with
Okay.
yeah.
All right. Okay. All right. No, thanks for that. The other one was from Dr. Gelile. Toshona said that any risk of using a combination antifungal and steroid creams for inflammatory type of tinea corporis?
I just want to be sure a combination of topical instead of oral.
No, of using antifungal treatment together with topical steroids. Any risk for
Well, I would
inflammatory type
suggest
of
that
tinea?
because that is the risk of that you lower your own immune system and that you will have a tinea incognita, even though you combine it. So I know that sometimes it has been used also orally with prednisolone for patients with a very severe tinea capitis. But there has been some studies showing that it's if you use steroids either orally, the response, the mycological response is not better and faster than if you're only using the antimycotics. But there's a risk of maybe that the patient will become resistant. So it's only if you want to lower the inflammation, but I think it should not be done for a long time. I would not suggest it.
All right. No, thank you so much. And just the last one, it's or last two, it's a comment from Dr. Sidra. Said that Dr. Saunte, thank you so much. That was fantastic, very comprehensive, as well as very practical. I just want to ask personally with regards to your experience of the use of flucytosine for treatment of especially deep fungal infection that are recalcitrant to itraconazole.
I think you have more experience with that than I have. because these are not common in my country. So I
Okay.
would be very unhappy to give an advice on something that I'm not experienced in.
Okay.
We have very few deep mycosis here.
Okay.
So sorry, I'm not
Right.
able to help you with that.
Not a problem. Just one last question here. Would lasers be a helpful adjunct to recalcitrant cases of onychomycosis from Johan? Yes.
Laser for onychomycosis, yeah. One have to bear in mind that the laser are approved for the clearance of the nail, but not for the eradication of the fungus. So
Okay.
it can be add-on, and it can. I think that combination, maybe laser and antifungals, may help, but just to be aware that the approval is not for the eradication of the fungus, but for the clearings of the nail. But I always think in recalcitrant infections, especially of the nails, it's about removing dermatophytoma and about attacking the nail from different angles, combining oral with topical or maybe oral with laser. I think that will always be an advantage to combine different things in different difficult cases.
Yeah, that's all from us. We just want to say thank you so much, Dr. Saunte, for such a brilliant presentation. You took us from basic clinical, basic sciences and took us right through to treatment. Thank you so much for everyone for joining, and you can still get this lecture as you subscribe to our YouTube channel. Thank you so much. Watch out for our next webinars in January. A good festive season. Thank you.